We hope to cover in the webinar today why are early warning systems such an important component of addressing the morbidity and mortality that exists for Texas. What's the evidence supporting them? What are parallels and alignment between other efforts that are going on in Texas for maternal safety? What are essential components to early warning systems? And what did we see during implementation of this quality improvement project that might help people who are relooking at an existing early warning system or thinking of developing one within their own? Next slide, please. So this slide is probably not a new one for many of you who have been to many talks on maternal morbidity and mortality, but just to give us background and to frame why early warning systems are so important, we know that maternal mortality is essentially the tip of the iceberg behind serious adverse events. And many of those adverse events are known as severe maternal morbidity. In general, one of the things commonly referenced is that for every one maternal death, there are about 100 instances of severe maternal morbidity. And severe maternal morbidity is very specifically defined as during a delivery hospitalization, so either with a vaginal delivery or a C-section, do women have any one of several ICD-10 code events that we know are highly related to a serious adverse event. That might include mechanical ventilation or a heart attack or an MI or sepsis. We also know that maternal mortality is a huge focus right now within Texas and within the United States, and something that we are very strongly trying to work on reducing. But it's a very important population level measure of how women are doing within a society, and we know that things like any one maternal death has a huge ripple effect on families and communities and the society around it. And that's why anything that addresses maternal mortality is very important. Next slide. This is data from our own Texas Health data from the maternal mortality site, looking at deaths by cause in Texas from 2016 to 2019. This does look a little bit different in recent years. We know that during the COVID pandemic, the leading cause shifted to infectious causes, both those that were represented by COVID-19 and others. But the common pattern seen here within our state that mirrors what's seen in many others include things like cardiac events, hemorrhage, sepsis, hypertension, cerebrovascular events, pulmonary embolism being some of the leading causes of maternal mortality. Next slide. Thus linking to why maternal early warning systems are so important. This is data from California's Maternal Mortality Review Committee looking at the causes of death and the leading reasons why. And they found in many of those causes that I just referenced, delayed response to clinical warning signs, which is represented by the blue bar in this bar graph, was the leading cause, meaning failure to respond and prevent what we now know is a high likelihood of impending adverse event was one of the leading preventable causes in many of these maternal deaths. And our own Maternal Mortality Review Committee has previously published very similar findings. Next slide. So what is a maternal early warning system? And I think this is a very important discussion because in trying to implement them, we realized many hospital teams or systems think or thought they had one before we started this work. So overall, to simplify it, it is both a alert and a response system. And if you are missing either part of that, you do not have a maternal early warning system. So reasons why they're important: we know that delays in recognition, diagnosis, and treatment precede the majority of deaths from the top leading causes of maternal mortality in our state and in others. Recognizing them is a little bit more challenging in pregnant and postpartum populations because of the physiologic changes that happen in pregnancy. It means that often things that are flags in non-pregnant folks do not overlap what they might need to be for pregnant or postpartum patients. And often because things like pregnant women might have a faster heart rate at baseline, it might lead to some cognitive biases that include, oh, that's just normal for pregnancy, it's not a clue for sepsis. And then finally, early warning systems are proposed to facilitate that timely recognition, diagnosis, and treatment to prevent development of critical illness. Next slide. So in the work that we did previously in a partnership with TCHMB, our State Perinatal Quality Collaborative, as Susan mentioned earlier, and worked during the AIM bundle implementation of the hemorrhage bundle to generalize it to as many hospitals as were interested in implementing early warning systems. We defined it as a system of escalation and response based on predetermined maternal vital signs and maternal symptoms. And it was developed to streamline that process. Next slide. So there is evidence prior to our doing this work about the importance of early warning systems. There's also a number of different tools. So a lot of the earlier referenced work actually came from British systems that often were referred to as MEWS or Maternal Early Obstetric Warning Systems. The table on the left is from what was formerly the Council on Patient Safety and recommendations from them of using a criteria system, meaning any one of these triggers should lead to activation of a maternal early warning response. And then the figure on the right is from a publication from Larry Shields from work that was done at Dignity Health. And this is a maternal early warning trigger tool. In this tool, people can either trigger based on one vital sign that is severely abnormal or two that are of a certain criteria. And I think a really nice feature about this mute tool is that you can see in this illustration using your maternal early warning system as a pathway into each of the existing bundles, sepsis, cardiopulmonary hypertension, and hemorrhage, and using MEWS as a recognition system to then lead you down the work for each one of those pathways. Next slide. So in this earlier publication, they went through pre and post implementation of this mute tool to show what the difference in their patient outcomes might be. And they tracked it along these four pathways, as I mentioned earlier: sepsis, cardiopulmonary hypertension, and obstetrics, or obstetric hemorrhage. One of the things I do want to highlight is often people might fit a differential diagnosis in multiple of these bundles. So somebody with a fast heart rate, depending on what other features they have, might fall in sepsis or in obstetric hemorrhage or in cardiopulmonary. And so often keeping that wide differential diagnosis is really important. Next slide. In this publication, they tracked pre and post implementation of this early warning system tool and found a significant decrease in severe maternal morbidity, composite morbidity, and in episodes of eclampsia. They also found a decrease in hemorrhage, transfusion, need for hysterectomy, and then very interestingly, an increase in sepsis. And I think this is really important as our state walks down the pathway of the sepsis bundle, which we have just started via AIM work. And knowing that one of the key features of sepsis is under recognition or lack of recognition that it occurs. And so while an increased incidence might look challenging and like it might not work in this system, I actually think it means it helps with detection and hopefully preventing further morbidity by using something like an early warning system tool. Next slide. Other publications have looked at different morbidity events and how each of these different systems, referencing MEWS, MEWS, MUTE, which I just mentioned, and looking at how sensitive and specific they were in predicting severe adverse events. And certainly each of them have a little bit of a difference based on the morbidity event, but overall had reasonably high sensitivity and specificity in predicting a serious adverse event for the patient population studied. Next slide. In summary, they found that the maternal early warning system identified had a very high median sensitivity and specificity, but might not have had as high of a positive predictive value, but a very high accuracy in predicting death. with an area under the curve of greater than 80% in critically ill obstetric patients. I'm going to pause because I think one of the things I've learned about interpreting literature is folks can read the same thing and have very different conclusions out of this. And I think one of the challenges in early warning systems is often people say, well, it doesn't always mean that something is going to be wrong. And people are really concerned about alert fatigue, meaning the system goes off, they come to see the patient, and there was nothing wrong. I think a flip side of interpreting it, and one that I tend to favor, is perhaps that process actually prevents the adverse event by having gone down that pathway. And also, we're never going to be perfect. And if a system 100% predicted significant mortality or morbidity, we probably needed to have started at a step back. So while it isn't always going to show that your patient's going to have an adverse event, it has a very high sensitivity and specificity in a lot of the published literature. Next slide. Which leads me into one of my favorite quotes in quality and safety, which is the pursuit of safety is not so much about preventing isolated failures, even human or technical, which we know things like interpretation of vital signs is heavily human factor related, but more about making the system as robust as is practical in the face of its human and operational hazards. And I think that's one of the really novel and relatively simple features of the early warning systems that many of our hospital teams in Texas did. We took something that many people believed probably was happening, but wasn't happening with as high a degree of reliability as people would like, and was highly subject to cognitive biases, and tried to streamline that process. And it had pretty significant effects for many of our hospital teams. Next slide. So what are essential components? As mentioned before, the early warning criteria, so having agreed upon vital signs and maternal symptoms. And I'm going to come back to the maternal symptoms a couple of times in this talk. There are a number of symptoms such as unremitting headache or impending sense of doom that patients have again and again identified as having expressed to hospital teams and not gotten the response that they would have hoped to, and then ended up with significant adverse events. And we know they're intimately tied with things like a pulmonary embolism or severe preeclampsia, and thus they are critical components of early warning systems in addition to those vitals. The next essential component is prompt reporting, and that includes what exactly the notification pathway is, to whom, by whom, when, and what the escalation process is if the anticipated response isn't able to happen, and then bedside evaluation. This was one of the harder things for many of our teams, especially many of the rural hospitals in Texas, to work on, with bedside evaluation resulting in standardized closed loop communication and documentation. Next slide. So going through some features of each of these essential components and referencing some of the lessons learned in Texas hospitals and how they help us with ongoing quality improvement work, I'm going to cover in the next few slides. Next slide. This is an example of the protocol that our hospital teams used when we started this work in 2018 with implementation of the hemorrhage bundle in parallel. We started out with telling teams they could really pick whatever early warning system they wanted to use. Many of them said, look, we don't have anything, give us a recommendation, so that we're all using something similar. And so this is relying on that original Council on Patient Safety recommendation, which is just one trigger. Now, does that mean that using a mute tool is not the right way to go? Absolutely not. I think they all have pros and cons, and the implementation within your system and how effectively you use it is really the key piece. But this is where we started with our example algorithm for Texas hospitals. I'm also going to say I think we are one of the first states. Washington State also did an early warning system as one of their first bundles, but certainly the size of our Texas hospitals made this unique, and I think we learned a lot of lessons that I'm really happy to share. We were able to leverage and share with National AIM in development of a recent early warning system toolkit that really was from the experience of implementation here. So starting with early warning criteria, leading to the hospital-based triggering of the maternal early warning system, notifying the responding provider, having a designated time when that responding provider is supposed to be at bedside. And we set the kind of floor of safety at within 60 minutes. because this does look really different in different hospitals and geographic locations throughout our state. We have a really diverse level of maternal facilities, distance from the hospital, who is in-house versus not, types of supporting providers. And so each hospital really had to work with what would work for them. Many of our hospitals that have 24/7 in-house providers shortened this to 15 minutes. And if they are not able to get somebody at bedside within that time frame, knowing ahead of time who you're going to call and what the response should be, and having that part of the readiness aspects of implementation. And then after the bedside evaluation occurred, going through things like differential diagnosis, trying to avoid anchoring or confirmation bias, and integration with existing hospital quality improvement bundles is the process that our hospital teams implemented. Next slide. So that meant they had to agree on what would be MEWS triggers within their system, and how they might leverage existing hospital systems for non-pregnant patients, and what vital signs to use. And so one of the tools that TCHMB developed is this badge buddy, which hospital teams could order and then adapt if they wanted to change things, if they used different early warning system triggers. But that way everybody knew what the vital signs and the symptoms that should trigger the early warning system were. And it was part of everyday clinical workflow. So not just relying on electronic medical records to flag when it's abnormal, but having everybody know exactly what those should be. Next slide. As I mentioned earlier, we were really happy to work with National AIM on implementing the Maternal Early Warning System Resource Kit, which just recently was published. And a lot of the tools that our Texas teams developed and worked with are now referenced for everybody else via this AIM Resource Kit. Another really nice feature, as you can see on the right, in the blue and purple boxes, they have examples of successful programs or policies, many of which leverage a lot of the things we discovered along the way here, and then resources in purple that hospital teams can reference. Next slide. Can you go back one more? So the next essential component is prompt reporting, and what that alert and response process looks like. Next slide. So this is the other half of that badge buddy, which is having hospitals outline exactly what the workflow should be for an early warning system. And that includes validation of the vital sign, immediate notification, and using very specific and direct communication. And I'm going to talk a little bit about that in a second. Notification of a charge nurse or another escalation pathway to help with things like data collection and following the escalation protocol. Escalation if the provider is not able to respond, confirmation and closed loop communication, and documentation, all of which were critical components of this next phase of MEWS. Next slide. This is something that our internal team learned a lot about during implementation, because as I mentioned earlier, every hospital is set up a little bit differently. And so what works in an urban level 4 is going to be very different than what might work in a rural level 1 hospital. Everyone has different available providers. And so hospital teams did a lot of really innovative work in figuring out who the early warning system response team might look like. So as I referenced earlier in, for example, an academic urban level 4, their early response might be to a resident with an escalation pathway to an in-house hospitalist, and they might need somebody at bedside within 15 minutes. Whereas a hospital that doesn't have 24/7 in-house OB providers, or might have a fairly long distance that they are from the hospital when you trigger your early warning system, many of them did really innovative things like use their rapid response team and train them in MEWS response, or use an emergency medicine provider. We saw a lot of really interesting tools like hospitals having pre-printed roll cards. So as they triggered MEWS, if it was a non-obstetric provider that wasn't as familiar with their unit, which we know happens a lot when people have to wear multiple hats in, for example, rural settings, they gave them exactly what was expected of them on that roll card when they came and practiced it in simulation. So the notification and escalation really became very hospital unique. There are a lot of common pathways that we saw that I referenced earlier, but the most important thing was having the hospital know who the first line response provider was and who the second line needed to be. Next slide. And then process mapping exactly what was happening at each unit from vital sign collection all the way through vital sign resolution. And many people learned a lot along this process. We heard a lot of stories of things like blood pressure cuffs being attached to patients and just taking blood pressures and no human being involved in that process and it ending up in a machine and getting noticed 2 hours later. And a lot of work had to go into minimizing the time between a vital sign being checked and being able to set into place the response system. But really mapping out what that looked like in each unit and trying to work on efficiently minimizing the time between each event, knowing who the designated provider needed to be, what the communication looked like, and what the expected response team would be. Next slide. And then finally, if the provider is not able to respond, and this is really critical because I think in the world of obstetrics, often that provider might be in a C-section or managing a different emergency like a hemorrhage, or a phone doesn't work. Having a process so that the patient doesn't just have to sit there and wait, but still has a timely bedside response and working on what that looked like in each different hospital system. Next slide. Another big area where we learned a lot is what the bedside evaluation and communication piece needed to look like. And when I say learned a lot, I mean along the lines of all of the different cognitive biases that go into evaluation and management and resolution, and then also the vulnerabilities that happen in communication. Next slide. So what is supposed to happen during the bedside evaluation? That is where the initial differential diagnosis is generated. We knew that this was a particularly vulnerable area where there was a lot of things like normalcy bias or confirmation bias or anchoring bias. So trying to build a system that helped prevent that with having defined, this is the differential diagnosis for this vital sign as an example. Initiating resuscitative and diagnostic interventions that hopefully lead to a reduction in developing an adverse event. And then also acknowledgement that that doesn't override or replace existing other emergency systems. So if your system would call in a sepsis response team, you still do that if sepsis is part of your differential diagnosis. If you had a hemorrhage response team, you would still call them in and having those teams work together, but it doesn't ever override one. It just is kind of the central point that often unites them all. And then having a chain of command to escalate clinical care concerns. Next slide. As I mentioned before, ways to ensure that we don't fall subject to some of the common biases in what the differential diagnosis should be and missing others. And I'm going to, as an example, many of these vital signs have quite a long, that could trigger MEWS, have quite a long differential diagnosis and might overlap. So for example, tachycardia with a heart rate of over 120 could be hypovolemia from hemorrhage, could be sepsis, could be something related to a pulmonary embolism. So the potential pathways are quite long, and making sure people don't move down one and miss others. A lot of teams did really creative things, such as creating smart phrases that would populate with each maternal early warning system trigger what possible differential diagnoses were, and then opening up order sets so that they could walk down all of that evaluation to help prevent some of those typical cognitive pitfalls. Next slide. Also, as I mentioned in a really core thing, this ended up being pretty foundational, I think, for the next few bundles that we did and are going to do. So it is kind of the core readiness and recognition component to many of the AIM safety bundles. Obviously, we worked on it during hemorrhage, but it became absolutely foundational for people during severe hypertension in working on timeliness of treatment for severe hypertension. And now as we begin sepsis, I think it will really help with diagnosis of suspected sepsis, leading to a higher awareness and hopefully prevention of sepsis and septic shock. Next slide. in the communication area, exactly who needs to know and what needs to be communicated. And I'm going to sidebar really quickly and tell you, as a maternal fetal medicine physician, one of the more common things I hear in communication errors is where the person calling, for example, a consult might say, you know, the MFM provider refused to come see the patient. And then when I talked to the MFM provider, they did not even realize that the person calling wanted them to see the patient. They thought they were explaining what was going on and asking for an opinion, whereas the person thought, clearly they'll know with the situation I'm describing, I need them to come. But when no one says it, it sets you up kind of for hinting and hoping and having a very different expectation. So the nurse to clinician who's going to be the primary responder communication became really important, and we started working on scripting it, and I'm going to show that in an example in a second, but really starting with this is a MEWS trigger and ending with the expectation is you're at bedside within X amount of time that matched your hospital protocol. Next slide. Why is this piece so important? Because we know communication is one of the most common causes in most adverse events, and this is certainly true within obstetrics. So this is a cartoon trying to make light of what is a group of people who all had a different expectation of when they were going to lift the patient, all lifted a little bit differently, and then the patient ended up falling off the OR table. And that is why assuming often leads to a very different outcome, and where clear and specific and direct communication is really important. Next slide. We know from Joint Commission reports that communication is the leading cause, and if you'll just advance it one click, in most sentinel events, and so therefore working on the specificity and outcome and closed loop nature of communication is really important, and we also found that with these early warning systems. Next slide. Next slide. And then finally, a really key component of all of the different safety bundles is in the reporting and systems-based learning, which include this aspect of communication, of having a culture of multidisciplinary briefs, huddles, and debriefs. And we also found this was really important for teams, especially as they were starting off with MEWS implementation in each MEWS trigger event or in the ones that led to an adverse event, doing those huddles and debriefs to evaluate, you know, what needed to go differently to have a different outcome. Next slide. So I just want to illustrate and compare and contrast two different systems. This is something that Dr. Davidson and I created in an earlier webinar that we did from TCHMB, really to show the difference in an early warning system and what one isn't and is not. So I'm going to paint here in Hospital A as an example somewhere in Houston. Next slide. So in this, at 8 a.m., a patient's vital signs are checked on the postpartum unit and her blood pressure is 165/103. Next slide. The patient care tech in this case, their process is to check vital signs, and then when they sit down after a number of patients, to import it into the electronic health record. So at 8:45, they document it in the electronic health record. Next slide. When the provider who's caring for this patient logs into the EMR next at 8:50, which is 50 minutes after the original vital sign, they note the severe hypertension blood pressure. And so they call the bedside nurse and ask, can you repeat it so I can see if this is a sustained severe range blood pressure? Next slide. At 9:15, the nurse goes back and reassesses the vitals. If you can advance one slide. And in this case, at 9:20, they call back and say, yes, the blood pressure is still severe. So this is now an hour and 20 minutes after the initial severe range blood pressure, and it's 170/106. And now the patient has a headache, and the doctor says, thank you. So I'm just going to draw attention to, they don't give orders, they don't tell the nurse what's happening. Let's say they end up going quickly to do a delivery and then presenting to the patient after that, and at 10 a.m., they finally are able to come to bedside. Will you advance? When they see the patient, they have a headache, 7 out of 10, and visual field disturbances. And so at that point, they order preeclampsia labs, emergent antihypertensive treatment, Tylenol, start a vital sign protocol of every 15 minutes, and say to transfer the patient to a higher level of care so that magnesium sulfate can be administered. Next slide. So at 10:15, the nurse gives the antihypertensive treatment and Tylenol. This is again 2 hours and 15 minutes after the first severe range blood pressure. Next slide. And then they continue taking blood pressures every 15 minutes after giving this antihypertensive. And finally at 10:45, the blood pressure is now in a non-severe range. Can you go back one more? There. Okay, so that's one example. And I'm going to compare and contrast them just in a second. Now, let's say Hospital B has a maternal early warning system. How might that look different? Next slide. So at the same time, the patient care tech checks the vital signs at 8 a.m. and the blood pressure is 165/103. Next slide. Since they have a maternal early warning system, they check their badge buddy and see that this would be a MEWS trigger and know that they need to validate it within 5 minutes. So immediately call the bedside nurse and tell them this patient had a severe range blood pressure. Next slide. That phone call happens to the nurse, notifying that this patient had a MEWS trigger vital sign, and the nurse knows exactly what to do in that situation. Next slide. She comes to bedside and validates the vital signs at 5 minutes. Next slide. She calls the responding provider at 8:07 and does SBAR communication. So this is an example of what I was talking about earlier with very specific and direct communication that's scripted. And in this report in situation, they say this patient had a MEWS trigger with a blood pressure of 165/103. Background, she's 35, G4P3 at 32 weeks. Assessment, her headache is 5 out of 10. She doesn't have visual changes and she is not hyperreflexive. And then the next piece is, I will see you at bedside within 15 minutes for an evaluation in following their MEWS protocol. Next slide. The physician is at bedside by, then she notifies the charge nurse by 8:10 that this patient had triggered MEWS, and that helps follow this hospital's policy for tracking MEWS outcomes and to make sure they have the added layer of escalation in place. Next slide. The bedside provider is there within 15 minutes, which in this case is at 8:20. Next slide. In this bedside presentation, they're both there and discuss the differential diagnosis, what the plan of care would be, and reevaluation, and when to be called back again, and close it with closed loop communication or check back communication to make sure that both of them are on the same page. Next slide. Patient gets treated at 8:28 with the emergent antihypertensive, and then at 8:40, she goes to document these events in the electronic health record. In 15 minutes, the vital signs are rechecked and the patient has now a non-severe range blood pressure. Next slide. So in this case, the initial MEWS trigger was at 8:20. The time to bedside provider evaluation was 20 minutes. The time to treatment was 28 minutes, and the time to resolution of the MEWS trigger was 58 minutes. Next slide. So in going through these two different scenarios, and you can keep just forwarding as they publish, I'll just taking a brief moment back. Our state just finished implementing the AIM severe hypertension bundle. And one of the key components to that is the desire and goal of treatment of severe range blood pressure within 60 minutes of the first severe range blood pressure. In my opinion, this is really only possible with a system like Hospital 2. And the reason this is the recommendation from ACOG and part of the AIM bundle is we know from looking at maternal deaths related to severe hypertension, the most common cause is stroke, and one of the most common features is delayed treatment of severe range hypertension. And so we know that minutes matter in this setting. And if you're trying to do treatment as urgently as possible and ideally within 60 minutes, you really have to have a very streamlined process. So while neither scenario is probably outside of clinical reasonableness, you can see that scenario 2 resulted in a much faster response time, is the only one that resulted in a time to treatment of less than 60 minutes and a much faster time to resolution of the severe range blood pressure, which we know is critical in reducing severe maternal morbidity and maternal mortality related to preeclampsia. Next slide. So hopefully that helped illustrate why early warning systems really kind of connect the pieces between what many folks think is happening, but eliminate a lot of the variability that can occur and a lot of the cognitive biases that often occur in these sorts of phone calls. So really everybody knowing exactly what should be a criteria, communication being specific and direct, having an expectation of when treatment needs to occur, and then closed loop communication about the ongoing plan of care. And you can see those illustrated in that second example. Next slide. Okay, so how does this align with Texas's ongoing maternal improvement efforts? Next slide. So in a number of different ways. I know I did a lot of illustrating what's going on with different safety bundles and how MEWS aligns with them all, but the other thing is in regards to levels of care. And as probably many of you know, Texas is the first state to make it required for hospitals to undergo designation as either a level 1, 2, 3, or 4, based on the resources they have to support patients of different levels of illness. And a critical component of levels of care includes this specific language, which is that all levels have to have written guidelines or protocols for conditions that place pregnant and postpartum patients at risk for morbidity and mortality, including promoting prevention, early identification, early diagnosis, therapy, and stabilization, which essentially is an early warning system. Next slide. In each of these safety bundles, we have already statewide done hemorrhage and hypertension and are in the process of implementing the sepsis and obstetric care bundle. Early warning systems are really key components of the readiness and recognition of each of these bundles. And so it really serves as an important framework to be able to effectively do each of these bundles and then move into the response section. Next slide. I'm going to pause really quickly and say some of the dialogue that we've been having about sepsis is we know it was the leading cause of maternal mortality in 2020 and 2022. A lot of people attribute that to things like the pandemic. But really in looking at it, it often uncovered a lot of gaps that were already there that just got really amplified during the pandemic. And so we know that some of the main barriers in sepsis are things like failure to detect what could be suspected sepsis, and then lack of triggering into the response portion, which might be timely antibiotics and IV fluids and escalation of care. All of that is very nicely supported by early warning systems. So even if a hospital doesn't have a lot of sepsis cases, I think walking through sepsis implementation and MEWS implementation is going to help every single patient that comes in the door in really utilizing your early warning system to put you down the different pathways. Challenges that we saw with maternal early warning systems in Texas hospitals. I think the biggest one was integration into the electronic health record and using that in a way that actually led to earlier notification and response. Throughout all of the work that we've done, tracking obstetrical outcomes and the data collection behind it remains a challenge for hospitals in resource allocation, and we certainly saw that in MEWS. Being able to prioritize and have the time, space, and resource protection to do simulation-based education and training for MEWS, and then what the escalation chain of command would look like. Next slide. And I'm going to come back to kind of each of those features as we go through what this now looks like in the national AIM bundles from lessons learned in Texas. So this is going through a bit of the nitty-gritty in MEWS implementation. So as many of you know, the AIM bundles are set up essentially like a driver diagram with what we now call the 5 R's, which is readiness, recognition, response, reporting, and respectful care, representing the primary drivers of each main morbidity event. And so in implementing MEWS, we use that AIM framework to help teams in figuring out what they needed to put in place. And so as an example for readiness, we recommended coming up with a team of champions that's going to work on this, selecting which specific vital sign and patient symptom criteria, as I mentioned before, creating that process map, a MEWS trigger, protocol, education, and then figuring out how you're going to track data. Next slide. We were really proud to see that this similarly ended up in that national AIM implementation guide. Under readiness and looking at things like identified strengths and weaknesses for MEWS implementation. The readiness assessment is something that we used with Texas hospitals to help them figure out what they already had in place and what they might need to build on to implement MEWS. And then many of the examples in this resource guide came from work done via Texas and TCHMB and the AIM work that you all did. Next slide. In regards to recognition and prevention, having that standard protocol, developing what validation looks like. We ran into a lot of if people during their process mapping process realized that, for example, the blood pressure cuff would be attached to the patient's bed rail as opposed to the patient, and then have a very low blood pressure reading because of it, making sure it was actually a real vital sign before triggering the system became important for provider buy-in and to reduce alarm fatigue. So having that process laid out, and then what the notification process and escalation would look like. Next slide. A lot of this made it into that national AIM bundle, but then they also added really innovative things that I think are critically important that if we could do it again, we would go back and include in there. So if people are looking at strengthening or redeveloping or developing a MEWS system, I want to highlight those in just a second. Next slide. So they added in screening for current or recent pregnancy in all care settings. And TCHMB during the severe hypertension bundle implementation worked on a postpartum preeclampsia in the emergency department quality improvement project and learned a lot that I think aligns really nicely with this. And if we could do it over, I think would have added this from the beginning in our MEWS implementation. Training healthcare professionals and staff to recognize obstetric emergencies. As an example, a blood pressure of 165 over 110 is not an emergency in the ER for most people, but it is for a postpartum woman. So making sure as part of your recognition and prevention work that these are foundational elements that you're doing, and again, will help with every bundle coming forward. And the graphic that I've included there is actually linking to ACOG's new obstetric emergencies and non-obstetric settings toolkit. And I think a lot of that work also links nicely to work done during the PPED project. Next slide. The other thing that I think is critically important that we learned after this is making sure patients are educated in the early warning system signs and symptoms as well, so that they know to present back. And we know that a common kind of finding in many maternal mortality review committees is that patients will have had symptoms at home for a number of days before they come back in, and therefore their adverse outcome kind of perpetuated and worsened during that time, and that might have been the preventable time period. So these are tools that are heavily helpful in the patient education sign, the Hear Her campaign, both from the CDC and the Texas Hear Her campaign. And then on the right is the A1 post-birth warning signs with graphics showing patients what they are. I think another key thing is if you have a patient come in and say, I'm here because I have severe swelling, redness, or pain in my leg or arm, we have told them to come in for this reason, and therefore we need to make sure we are responding appropriately. Next slide. Other key components is going through what the data tracking will look like and build that in from the beginning, not after the fact. How are you going to know that you actually implemented your system? And we learned over and over that teams that didn't track when they were missing MEWS triggers often kind of missed the critical area. So they thought they were doing great when MEWS was triggered, but if 90% of the time it doesn't happen, that's where the work needs to happen. So making sure you know who, what, where you're going to record as far as information and how you're going to get it to tell if what you're doing is improving care, if you need to adjust. Next slide. In response, as I referenced earlier, having that designated script for communication between the nurse and the MEWS responder, having that escalation process, and then exactly what the timeframes behind those look like. Next slide. This is where we learned a lot on electronic health record integration. And I think many teams tried to integrate it fully from the beginning, and that really delayed the ability to do small tests of change to see if the system was going to work. And so teams that did small little pieces and tested it were much more effective at getting to sustainable MEWS implementation. So this included things like not just the alert trigger, but data tracking in flow sheets, order sets, smart phrases, all of those different things are examples of electronic health record integration. Next slide. And one more slide. So as an example, people did really innovative things with either having hospital dashboards or labor and delivery dashboards, flag different colors if patients had MEWS triggers, having alerts go to whatever portable communication method they were using in their hospital, or having like best practice alerts flag in the EMR, or just using it as people knew what it was and a person escalated it. All of those things were things people used. But as far as other examples for data integration, many teams did created flow sheets that the bedside RN would say, this is the time the trigger happened, this is the provider I notified, this is the time they were at bedside, and this was the intervention. And then they could run reports on it to see when critical components and data tracking occurred in their MEWS implementation. And then finally, order sets for different differential diagnoses and different bundles that they were going to go on based on the MEWS trigger, and smart phrases to help with documentation and reduction of cognitive biases. Next slide. As I mentioned earlier, I think this is my favorite R, which is reporting and systems learning. And this is where that data tracking and things like the briefs, huddles, and debriefs became really important. Next slide. Why is this so important? There is unfortunately an abundance of evidence that just having a protocol does not change the outcome. It's actually the implementation of the protocol and being able to measure the implementation that is most strongly related to the outcome. So are people actually following your MEWS protocol? Are they triggering it? Are they responding? Are they doing a difference in intervention? Next slide. And so as part of that, we created structure, process, and outcome measure, different quality measures for hospital teams to collect on to show what their implementation looked like. Next slide. The people who were not able to do some sort of reporting from the electronic medical record or run a report on the flow sheet or all vital signs, this is a tool example for just bedside collection to get at that information to help. And often it was done with just a sample of people. And people were just as effective in being able to show whether or not it led to a difference in patient outcome with a paper tool as being able to do it in other electronic medical reports, in my anecdotal opinion. Next slide. These were some of the MEWS data sources that hospitals were collecting. I think a big thing is, things like how many providers were educated, what percentage of patients trigger your system, what percentage of patients should have triggered and didn't. And that often led people to understanding where a lot of the work needed to be. Did you have a policy? Was this included in handoff reports and in communication? And then some of the other outcome related measures that tied into what we were doing with the hemorrhage bundle. Next slide. And then finally, respectful and equitable care. So at the time we did this bundle, that aspect for AIM did not yet exist. But I'm proud to say I think we did a couple of innovative things that really helped with this being more effective. And the first one is we included a patient with lived experience in our core MEWS development team. Her name was Leah. She has come to a number of subsequent TCHMB and AIM efforts as part of Mama's Voices. But she was a patient who had a significant lived experience with an adverse event and was part of our internal committee and constantly provided us with really valuable recommendations on how to make this most effective for patients. And then the importance of including the patients as valuable members of their care team, including letting them know what the urgent symptoms they needed to report to their provider were. Next slide. And a lot of this has made it into that AIM implementation guide toolkit, including a lot of the things that I referenced earlier with the Hear Her campaign and the post-birth warning signs. I think this is going to be just as critically important with sepsis bundle work in the future, and in making that a critical component of how we bring this to our patients and teach them what to bring forward and come in sooner. And they have examples linking a lot of those materials